Mary Cuney, Spokane County Commissioner.
Chuck Hafner, appointed citizen.
Bob Lutz, County Health Officer.
Ray Byrne, Environmental Public Health Division Director and Interim Administrator.
All right, with that, we'll go to citizen input. We have 6 people today. And again, there's 3 minutes, and Vice Chair Wick will be holding up some signs as you get closer. And if you don't see the sign, I will remind you that your time's done. So we'll start out with, looks like Miranda O'Callahan, if I've got that right. Is there a mic up there? I can't see it. Yeah, okay.
Hi, my name is Miranda O'Callahan, and I have a 15-year-old daughter who is a vaccine-injured child. Sorry, I thought I was going to hold it together. So, I think it's important that you know that I'm not against vaccines. I have 3 children, and all of them are current on their vaccines. But there's one in particular that I've always had reservations about. And at every well check appointment, you're always felt very pressured into having your child receive this vaccine. And that was the HPV vaccine. So every time you're at a well check, you're always pushed and pushed and pushed to give your child this vaccine. Always decline, but when you decline, you feel like you're a negligent parent. You're repeatedly guaranteed this is a safe vaccine, there's no reason you shouldn't give it to them. So after years of holding out, I finally gave all 3 of my children the vaccine. Within weeks of it, my middle child started suffering symptoms. It began with a hand tremor, and then she started losing feeling in her legs. Her feet became numb, her legs became numb. It increased up her legs. We reached out to the pediatricians, who then referred us to neurologists. She's been seeing a neurologist for the last 2 years. She's on medication to help control the symptoms, but cannot stop taking it because they return as soon as she quits. She's been a lifelong gymnast. Before this vaccine, she was a very healthy, active child. She'd been a competitive gymnast all of her life, track athlete, swimmer. This vaccine has impacted her. There are days that go by that she can hold it together and the medication helps her. Some days she can't even get through a high school practice because of the pain in her legs. She's now resolved to a life of medication with no answers. There are no resources available for vaccine-injured children and families. And when you speak to health professionals, they look right through you and continue on when you broach the subject. We deserve to have help, and she deserves to have justice. The people need to be educated and have resources available to them. My child was perfectly healthy, fit, and strong prior to this vaccine. And now she's a child that will live with chronic pain, be forced to medicate. She's suffered depression and anxiety because of this, has gone through counselors in addition to her numerous appointments. Thank you.
Thank you, Ms. Callahan, for today. And next, we have, I believe, Lorna Callahan.
Hello, my name is Lorna Callahan. I am 15 years old. I received the Gardasil HPV vaccine in July of 2017. Before that, I was a lifelong competitive gymnast, a club swimmer, and a school track athlete. I was extremely fit, very healthy, and able to do hours upon hours of physical activity. But after receiving that vaccine, I developed a hand tremor, which made it hard to hold pencils most days. My legs would go numb, cold, and develop purple splotches all over them, and I could barely lift my feet off the floor. I had to sit out most practices for my high school sports of swim, track, and gymnastics because they had become too painful and my body couldn't move enough to do them. I could barely finish a warm-up, and I would cry out of pain and frustration every day. My body was failing me. I went from super strong to barely able to do 5 squats or walk up the stairs. I've been on medication after medication, too many for me to count. My body cannot function without daily medications to help control my symptoms and manage my pain. There are no resources to help me or my family, and doctors won't listen to what we have to say. This vaccine changed my life in a devastating and detrimental manner. I now live a life where pain is my new normal. Thank you.
Thank you, Ms. Callahan, for sharing with us. Next, we have Jacqueline Galloon.
Hello, Jacqueline Galloon. Can I move this? Can we move this? Can I move this? Okay. I feel like that's in my face. Okay. Okay. Let me start over. Okay. Hello, I'm Jacqueline Galloon. I have been speaking here since February of 2017, and I want to point out that another month has gone by, and we are still not an agenda item. And we have been requesting a roundtable to address various scientific aspects of vaccination policy and school exemptions. At one point, we were told this was going to happen, and it still has not occurred. Yesterday, Dr. Teresa Deischer spoke here in Spokane about the risk of residual human DNA used a substrate in vaccine production. Dr. Deischer is the discoverer of the human stem cell, of adult human stem cell, and has multiple patents and decades of employment in the pharmaceutical industry and dealing with the FDA. It has now finally been acknowledged that this residual DNA does exist in the human cell line vaccines, but the excuse has been the amount is too low to trigger any autoimmune conditions or to be available for a terrifying process called insertional mutagenesis, where the vaccine recipient incorporates some of the DNA into their own genome. Dr. Deischer has recently come into possession of a study showing that the amount of DNA that will cause a woman to go into labor, which is an immune activation event to expel the infant, it is at a lower threshold than the residual DNA found in the human cell line vaccines. I would really like you to see this information, and I can provide you links to our scientific presentation on the subject. It's about 45 minutes, very valuable information. By the way, the human cell lines were not in the original MMR, and it started in the MMR2 in the 1980s. And Dr. Deischer has very compelling injury showing that injuries with the graph. Sorry, I'm messing up here. And the increase when the human cell line vaccines were introduced. The definition of informed is having The definition of informed is having or being prepared with information or knowledge. The definition of dissent is disagreement with the philosophical methods, goals, etc. of a political party or government. What is occurring now is not vaccine hesitancy. It is informed dissent. I am informed and I dissent. Thank you.
Thank you, Ms. Galloon. And next I have Laura Denton.
Hi, my name is Laura Denton. Are you all aware of the CDC's decision made yesterday to recommend the HPV vaccine, the very vaccine that they were talking about, for adults? Are you aware that the work group almost unanimously advised against it? Did you listen to the ACIP, the Advisory Committee on Immunization Practices meeting that occurred yesterday? Because I've listened to portions of it, and it was fascinating. I wish I could go back and listen to more. They provided arguments that anyone who has already been exposed to any of the 100 strains of the HPV vaccine will be more susceptible to disease if they receive the HPV vaccine. Are you aware that adults in a monogamous relationship have no need of HPV vaccine? That was one of the arguments of the work group. How many people between the ages of 26 and 45 do you know that haven't been sexually active? Because those are the only people who might possibly benefit from this vaccine. and all the others have a strong chance of increasing their disease risk. And yet, the CDC board voted 10-4 to recommend and add this to the vaccine schedule for adults. Do you think doctors will discuss these work group findings and concerns before injecting adults? Do you think most doctors will even be aware of those concerns, or will they simply know what's on the schedule? This kind of biased decision-making concerns me, and I think it should concern all of you too. How many other recommendations of the CDC are fraught with concern? How do you make your decisions? Blindly following the CDC guidelines is not how I choose to make my medical decisions for myself and my family. Right now, people still have choices, but what happens when they decide it should be a mandate to give the HPV vaccine for the greater good? I am not interested in accepting vaccine mandates ever, and I will be here as often as possible to share information and advocate for health freedom. And I hope that this board will protect our freedoms. Thank you.
Thank you, Ms. Denton. Rosemarie, and I'm not going to get your last name right, but Waldron. Thank you. Come on up.
My name is Rosemarie Waldron. I'm married to Thomas M. Larson now. He's my third husband. I've outlived the other two, and that's part of my story in which there is circulating some information that this august body has not yet received in the 22 years that I have since I began attending these meetings to give citizen input on a subject that everyone that has ever heard me speak has never known was available. Now, the first axiom of all law is the absence of evidence is not the evidence of absence. In other words, just because you don't know about something doesn't mean that that is in and of itself the proof that that something doesn't exist. A lot of people don't know about me, but that doesn't mean I don't exist. You are witnesses to that today. If you'd like to come and pinch me, you're welcome to. I will probably say ouch. Each one of you has been given a copy of the American's Creed, which I received when I graduated from 8th grade in Colburn, Idaho, which was back in 1953. The second page of what is being currently passed around, which will be the possession of the lawyer, your legal representative, when it ceases being examined by each of you. Unfortunately, I am bound by the fact that I must do the best I can with what I have to work with. And I don't have the bottomless pockets that the special interests spelled with an S as a $sign have, who oppose what I say and have consistently, since I came on the horizon of their awareness, assured everyone around me that I was either at best nuts or I didn't exist. If you will examine what I give you, you will see my childhood background. I honestly believe that I have been, by the hand of Providence, herded into doing what I, kicking and screaming for most of the time, really didn't want to do. But the fact is, truth is. And just because truth is denied by people with special interests and deeper pockets than mine doesn't mean that truth does not exist. Please give this consideration when you are being wooed to do things. And in closing, what I'm going to say is that fluoride, which is in water fluoridation, of which I am medically diagnosed allergic to, and it has been proven.
Ms. Waldron, thank
As
you.
a common
No,
denominator.
Thank you, that's
with
well over the 3
vaccines.
minutes. Thank you so much. Dave Schmidt.
I'd like to do a brief history of medical care in America, starting in the 1800s. It used to be locally controlled, locally based, people caring for people using traditional methods that are long established and proven as effective. If you look at the Chinese, there are thousands of years of practitioners who have acquired skills that are not necessarily objectified in science. I don't object to science, but I also recognize what they call artistic skills. Healing should be an art, not something you hand out in 5 minutes in a sterile room. It should be involved in a holistic sense. They burned down the sanitariums locally. The allopathic people in the late 1800s, they ran them out of the business. But they weren't in business. They were involved in their community, delivering care locally where it should be delivered. And they were skilled practitioners. And it's starting to open up again now. They're not being sent to prison for practicing the arts of healing. But when you get bankrupted at the end of your life for your care, this is not a system for the people, it's a system for the establishment. What the Lord gives, the Lord takes at the end of your life. That is wrong. Families have a right to build a foundation for the future. We have a triple whammy in our society. We've got the national debt, the national deficit, and the trade deficit. The twin towers of doom. That's what they call it on Wall Street. We have got to turn this model around. Out at Eastern, my mom started at the Mayo Clinic in Minnesota, which is renowned for coupling the past, the present, and hopefully the future. Health delivery for everyone at an affordable cost. She came here to this community in the 60s. There were 3,000 beds at Eastern State Hospital. Now there are 300, mostly occupied by the criminally insane. We have our mentally deficient, mentally ill people on drugs, out on the street, wandering all around like wild animals. This is not progressivism, it is progressive failure. We are not delivering health care to the people who most need it in our societies, and it goes for the school district too. The first people to go are the social case workers. It's a travesty, and it needs to, this allopathic method is not working.
Thank you, Mr. Schmidt. And that takes us to the end of community input today. And we're going to briefly go over the consent agenda, and then we're going to adjourn to an executive session. But on the consent agenda, the first item is the meeting minutes for May 30th, 2019. They've been distributed, and I'd entertain a motion for approval.
I move to approve the minutes as submitted.
Is there a second?
Second.
Okay. I heard Mr. Hafner there slightly by nose. So the motion for approval of the May 30th, 2019 minutes have been moved and seconded. Any discussion? Seeing none, prepare to vote. All those in favor, please indicate by saying aye.
Aye.
Aye. Any opposed? Any abstentions? The meeting minutes of May 30th, 2019 are unanimously approved. Next up on the consent agenda are vouchers for May 1st through 31st, 2019. Those were circulated earlier to the board. I don't know if there were any questions. No questions? Okay. I'd entertain a motion to approve those vouchers.
I move to approve the vouchers of May 1st through 31st, 2019.
I'll second that.
Any discussion? Hearing no requests for discussion, all those in favor, please indicate by saying aye.
Aye.
Any opposed? Nay. Any abstentions? Hearing none, they pass unanimously as well. We are now going to ask people to clear the room for executive session, and for how long, Ms. Fossum?
I think I just need about 5 minutes. How long do you want?
About 20, 15 to 20.
So should we say 20 minutes to start?
Okay, so executive session for 20 minutes. One part of it will be litigation, potential litigation pursuant to RCW 42.30.110, parent 1, parent I, and review of qualifications of applicants for public employment pursuant to RCW section 4230.110, parent 1, parent G. And we will reconvene at 1:15. All right, we finished our executive session at 1:22 after a couple of extensions that we announced. And now we're down to action items. We have one action item. It's a proposed administrative officer final review schedule. And Chuck Hafner is going to tee it up and perhaps make a motion. So,
You want me to talk about it for a second? So the committee has been meeting, and we're down to 4 finalists that we're going to be interviewing. And so we have a proposed schedule in front of you for an interview schedule to look at for the Health District Administrative Officer. And so I will make a motion to approve the Spokane Regional Health District Administrative Officer interview schedule.
I'll second that.
and just for folks in the audience, without going over all the details, it's a half a day on Thursday, July 18th, and a full day on July 19th. Any discussion? Seeing no discussion, all those in favor, please indicate by saying aye.
Aye.
Aye. Any opposed? Any abstentions? Seeing none, it's unanimously approved. And if people want to know more about that, we have some copies of it. All right, next is reports. The chair doesn't have anything of note to add to the good of the order. How about Board of Health Committee reports? I'll start out with Budget and Finance. Did you guys have any meetings since the last month?
We have not had a meeting yet, but we're due to have one in July, so.
Okay. And Councilmember Stratton's not here, but Dr. Lutz, any meeting from Education and Communication since last month?
As I mentioned earlier, we are essentially pending the policy committee meeting, which will then sort of allow the education committee to queue its work up,
That brings us to the Policy Committee.
which is meeting on July 11th, I believe, yeah.
18th?
18th, July 18th, correct.
All right. And the Transition Committee, anything more you want to say other than we've got this great schedule? Thanks for all your work. Just for the general public's knowledge, the Transition Committee meets Monday mornings at 7 in the morning, and they have met a lot, and they've gone through lots of people and lots of process. And so we're really grateful to that, and we're also particularly grateful to Ann, who staffs them. So also has to be here at 7 on Mondays and keep track of everything. So thanks, everyone, for that. That brings us down the Administrative Officer report. Anything, Ray?
I do have a couple updates. One, previously I had mentioned that we were going through reaccreditation with FAB. We did receive a letter on June 17th saying that we had been accredited. And then I also received a call last Thursday from Secretary of Health, Dr. Weisman, congratulating the district on achieving that. It's quite an accomplishment. We had a lot of people put a lot of effort towards that. So just a big thanks out to everybody who had a helping hand in that. And then also would like to recognize Patricia Rhodes, who is our FAB coordinator for that. And Patricia, if you could please stand up.
Good job.
So again, just wanted to say a big thanks, and, you know, it is, for the health district to be accredited, it's a tremendous amount of effort to go through that, but it's also a great recognition of the work that we do here and the transparency and quality control and stuff that we do, so, big thanks. Quick update on health policy specialist. We have closed that. We did initial interviews the last 2 weeks, have narrowed down to several candidates. Plan to do second interviews here in the next week or two, working around vacation schedules. So hopefully within the next few weeks, we will be making an offer on that position.
All right.
So, and then also on our PIO and Public Information Manager position, we're finalizing that PD right now. Hopefully we'll have that out, if not by the end of this week, by the first part of next week, and then start recruiting for that also. So, and then also, just wanted to, we had a employee that passed last October, and there was a event held on the 7th, June 7th, in recognition of her and what she did here. And she was program manager for the WIC program in health promotions. And I'll just read a quick, we did a plaque up in recognition of her, and I'll just read that to you. So it says, Deanna's commitment to children, families, and WIC program and the Spokane Regional Health District was unparalleled. Deanna was a champion for promoting breastfeeding in the community and instrumental in the development and approval of the breastfeeding and infants in the workplace policies at Spokane Regional Health District. Deanna was the first employee at Spokane Regional Health District to bring her child to work and launch the new breastfeeding policy. Deanna was a strong advocate for access to healthy foods, provided valuable nutrition education to WIC families, and helped Spokane Regional Health District WIC program receive gold-level breastfeeding certification from Washington State Department of Health. Deanna's impact in the community and Spokane Regional Health District will always be remembered. So just wanted to recognize Deanna and her efforts, and then also there's a plaque which I'll pass around for people to see. So.
Thanks.
And then the last thing that we had is several updates from Community and Family Services, and there'll be a two-part. Sheila Masteller, who is the Division Director for Community and Family Services, will take the first part, and then we'll have another employee do the rest.
Good afternoon, good to see you. I just wanted to thank you, Ray, for putting this on the agenda. There's a couple of updates that I'd like to share that is good news, coupled with the reality of the issues we're dealing with. So it's good news addressing challenges that we have. The first I want to share with you is the work that has been done over the last about year and a half between treatment services and our Nurse Family Partnership Program to provide more wraparound service for pregnant women who are in our substance program, medication-assisted program. We have been coordinating with that program, and NFP is now serving I think it's over 30 women who are in our treatment services and providing that one-to-one nurse support during their pregnancy while they're in treatment. One of the things that we've learned over that period of time is that there is so much education that needs to be continued to be done in the community, outreach to women who are using to help them get on medication-assisted treatment, as well as outreach to the medical community so that they're better informed about the importance of people staying in their treatment program when they're pregnant, because to go off of those substances can have harmful impacts on the babies. So we've been working on that and serving more and more women with really quite strong outcomes in terms of healthy or relatively healthy delivery, good bonding with moms parenting skills improving, and those babies being able to stay with mom. So it's really exciting. Through that work with Dr. Lutz's advocacy, we were invited to participate in a Department of Health grant earlier this year when they had some dollars to support continued outreach to pregnant women who have substance use disorder. We got an initial award of $70,000 to be spent by August that we use to fund a new position in our NFP program, which is a community outreach worker, a social worker, who is charged with outreach to find additional women who aren't already in treatment. We've had good success so far, and just this week I'm really pleased to announce that we've been re-awarded money for the following year, another over $100,000 that will allow us to hire another outreach worker. And some of the outreach is pretty creative. We're trying to go to spots where women of childbearing age and pregnant women are that we're not now reaching. So I'm really excited that we'll do that. We're hoping, we'll also through this program continue to develop materials that go both to the moms and their families about a healthy baby during your pregnancy and afterwards, real specific messaging. And we're also developing an outreach program to OB providers. We have a physician on our task force working on developing the materials to help them understand better the specifics of staying on medication-assisted treatment. And we're also partnering with emergency room physicians and providers for them to have increased learning about the importance of the treatment during pregnancy. So really excited about that grant. That's the good news, bad news. There is money that's coming to us. And because of the work that we're doing, it's pretty unique in the state. I'm hopeful that we'll be able to share the learnings across the state. So that's one update. Then I've asked Jen Hansen from our Neighborhood Matters program. Oh, please.
Is it a one-year grant, or do we have to provide the additional monies every year?
It's 1 year at this time, 1 year extension.
And so hopefully we'll have the funding be able to carry through with
yes,
that,
yes,
for that outreach.
Yes, yes. And as you know, the Health District is seeking quite a few additional funds through various programs to continue our opioid use support and treatment. So, and I'm optimistic that there will be continued funding for our work, just given the importance in the country and the recognition of that. And we're positioned well with the work that we're doing to continue to get support dollars. I'm hopeful of that, but 1 year at a time, federal funding,
Okay,
yes,
thank you.
yes. So Jen Hansen from our Neighborhoods Matter program is going to give you a little bit of a history and an update on one of our new programs that we're starting, Handle with Care.
Thank you, Sheila. So as Sheila said, I'm Jennifer Hansen, and I work in the Community and Family Services Division in the Neighborhoods Matter program, and I have the honor of working on family violence prevention policies as part of our agency's larger strategic goal to reduce trauma and family violence. So I was asked to speak with you today about the Handle with Care initiative, and I believe some of you may have heard bits and pieces about Handle with Care. Does this sound familiar to anyone? No? Oh, well, good. Then you're in for a treat, is what I will say. The goal of Handle with Care is to create an intentional, formalized communication process between police and schools. And so I have been working with ESD 101, District 81, and Spokane Police Department for the past year talking about Handle with Care and trying to figure out a good process for Handle with Care. And I'm happy to say that all three entities are really excited about Handle with Care, and I will tell you why. So the concept of Handle with Care is really simple. So an officer responds to a scene of a crime, or responds to a call on scene, and if school-age children are present and the call is something traumatic, so it could be a parent was arrested in front of the child, it could be witnessing domestic violence, it could be a drug raid. I mean, there are so many events that are very traumatic to children, and different levels of trauma based on age and resilience and coping strategies and all of that. And so all we're asking the police to do is make one phone call. And so District 81 will have a dedicated line, and the police are to call the line and say, handle the children at this address with care. And that's it. There's no confidentiality broken. They don't know the nature of what the child has experienced, and they don't need to. But what this one call will do is it provides notification to the school that the child has experienced something that could impact how their behaviors are over the coming days or weeks or months or years. And so we know that some kids, when they experience trauma, they'll act out, and they can, one kid can really disrupt an entire classroom. We see that often, and But a lot of kids also who are experiencing trauma will withdraw and be really inward. And a lot of times these are the star students who are really quiet and they're on the honor roll and they're experiencing a lot of different things at home and may need additional support. So this one call would be an early touch point that would allow the school to monitor the student and provide early intervention services if necessary. Our school system has a construct called MTSS, which is multi-tiered system of supports. And so it's a tiered level, recognizing all children will get a basic level of supports. And that would be like curriculum. All children are will benefit from curriculum. And it goes up the tier. And some kids are going to need just more intensive support and services. And a handle with care call could identify the kids that may need more help. It will also, it will also serve as a reminder for school staff to utilize trauma-informed practices when working with students. District 81 in particular has spent a lot of time and money on training staff to utilize trauma-informed policies, but it's not necessarily part of the norm of interacting with children. And so getting a handle with care call will change the lens in which the teachers that are interacting with that student, they'll know that something is up. And so rather than saying, oh my gosh, what is wrong with you today? It'll be, what happened? What's going on? And it will change the dynamic of just recognizing that kids respond differently when there are things going on under the surface. So what is next? Well, a lot of work, which I'm very excited to do. So I've been having focused conversations with key leaders within ESD 101, District 81, as well as the police department to try to get a better grasp on policies and procedures and how this could work. Later, in a couple months, once all the interviews, the key leader interviews are done, we'll be gathering here, likely, at the health district with our data center to go through a process flow activity where we'll decide with all entities, including leadership and line implementing staff, to inform this process. We're going to decide what the process will be, where are the opportunities for data collection, and what are the evaluation points that we are really needing to have. And so that will be coming in the next few months. And after that, we're also developing an assessment tool to utilize with the schools individually to assess what their training needs may be to make this implementation of Handle with Care a success. And that's going to take a little bit of time because right now there are 34 schools in the pilot area, which we wanted to start smaller, but we learned through just all the discussions that we needed to work with within the police their patrol areas, and so we needed to do either north side or south side, and so we picked north side. And so the earliest implementation of Handle with Care will be 2020, January 2020, which would be incredibly optimistic. And so many people still need to be brought into the conversation. And so we're trying to be really conservative with our timeline because we know that having an inclusive process, powerful discussions, and shared expectations will increase the success of the implementation. And so we'd rather do it right than do it fast. And that's it. Does anyone have any questions?
So nice to see you.
It's nice to see you
Worked
too,
together
Linda.
for probably 20 plus years. I really appreciate this project. How did you choose to do Spokane rather than a smaller district like West Valley or where you would have fewer schools to work and could start in a smaller district?
Well, it started with conversations, and this idea is not, I should have said this originally, this idea is not an original idea of mine. This originated in West Virginia, and so we were in the process of doing a literature review and came across this, this initiative, and I mentioned it to someone from ESD, who is the chair for the Domestic Violence Coalition, and that started the ball rolling in
in that direction, and also just contacts within Spokane Public Schools and within the police department. We knew it was a big bite, but it's the process. Once the process is established, it's going to be great for outlying areas too, and ESD wants to spread this regionally, and they'll provide the education regionally, but Spokane Public Schools provides their own in-service trainings typically. But hindsight's 20/20. Now it's getting really big, and so we're trying to scope it and just be really mindful that that may push the timeline out, but when we have a solid process in place, then it'll be really pretty smooth implementation.
Are you specifically talking about certain specific areas in the city of Spokane?
Yes.
An individual school or the pilot school? Because the resources are going to be unbelievable that the school district has to provide, let alone the other things. So,
Right.
so
Absolutely.
where do you think you're going to start first?
So that is a great question. So the school district is definitely aware of a need for additional services. And so, of course, with the cuts that, the significant cuts that just took place, we had some really hard conversations about whether or not it's ethical to implement Handle with Care if the services aren't there to meet the needs. And then where we landed is that the reality is that kids are suffering, and challenging behaviors are being exhibited in schools. And if we could bridge that for teachers to, trauma-informed practices typically don't cost money. It's a different way of interacting. It's a different lens that you use in working. So but for increased, like if there is additional services needed, we're going to be relying on a lot of community providers. And so that's another part of this whole process with bringing in who is doing what. I wish we were starting with one school. Working with the police department, that wasn't possible because it had to be an all or nothing approach, because the officers switch patrol areas so frequently that in terms of training and trying to get a foothold where everyone knows this is part of the process, not this is something you do only at this school. Like there wasn't, to make it more likely to have a successful implementation, it had to be a bigger area because it just needed to be part of the process. Does that answer your question?
Yeah, it's going to be quite a challenge because we're trying to do that.
Oh, I know.
Absolutely. And the challenge of the school district providing personnel for that.
Yes, absolutely. And so the other part of that too is that as needs are being unmet, we will be evaluating that. We're going to be documenting it, and that information is going to be really helpful in advocating for additional services if they're needed, it's really going to shine a spotlight on what is going on in our community. Child abuse and neglect is unfortunately, we have very high rates in Spokane, same as domestic violence, and they're very interconnected. And so if we can have touch points with kids and build skills early on and help the families, then we have a chance of interrupting the generational nature of this. So,
Yeah, and that's why I was specifically saying there's certain areas that probably have more of that than other areas. And,
it's everywhere, but yeah.
Okay, well, thank you very much.
Yeah, thank you. Anything else?
Jennifer, and thanks Sheila as well for your reports.
Great, thanks.
And that wraps up my report.
All right, Dr. Lutz, do you have anything as health officer?
Do I have anything? So just two comments before I actually get into the presentation. I want to thank Heidi, who I don't see here. So Heidi Wilson, as you know, is our community project manager, and she's been really sort of key in keeping our work, such as suicide prevention and opioid work going forward. And we had a provider event over the past weekend. We had about 70+ people register. A fewer number actually participated, but a really great opportunity to work with providers of all disciplines, not only medical providers, but I also talk about community health workers, nurses, really multidisciplinary. There was a lot of information provided, and then importantly, looking at how you work with individuals with opioid use disorder. So again, a very, very encouraging start to working with providers and really looking at how we, again, multidisciplinary approach to addressing it. I also want to make mention that, as you know, I serve representing health officers on the State Board of Health. And what I'd like to be able to do is just on a regular basis kind of give you an update as to what those meetings, what they're like, and sort of what we learn and what we work on. And so I was over there June 12th. The issues that we addressed, as you may or may not know, the State Board of Health is truly a rulemaking board. So we look at the RCWs and the WACs, and based upon what are the requirements and what the board's obligations are, there are certain WACs which we weigh in on for actual rulemaking. And so some of those are, for example, around newborn screening. And so it's also a multi-year process. What I'm learning is that, rulemaking, it takes months to years. And so oftentimes what happens is, for example, around newborn screenings, an issue, a new diagnosis, a new condition is identified, one that can be screened and there is treatment for. And so once that's identified, then the process begins, and you start creating the language around what that work will involve and what will be required by providers in the community to actually do the testing. And so we're looking at 3 different newborn screening tests, which will be added to the currently existing newborn screening going forward. Pompe disease, something I had never heard about in medical school, certainly still don't know too much about, something called MPS mucopolysaccharidosis 1, and then something called spinal muscular atrophy, all of which, again, can be screened in the newborn state. There is a good screening test, and importantly, there is treatment available for it. So again, those are some of the new conditions which will be added to the newborn screening panel going forward. We also learned, and again, this is relevant to Ray and environmental public health, there's something called the school rule. It's been sort of kicked around for almost 20 years, apparently. Legislation that was created back in 1999 that looked at what elements of schools should be evaluated, such as from the standpoint of exposures. I mean, so it's labs, it's cafeterias, it's sanitation, things of that sort. That is what was proposed. That's the legislation that's on the book. How do you actually enact it? How do you enforce it? Which has been challenging. And so what we've seen is that it has continued to come up for revision on every 2 years, and it keeps on getting passed down because right now we don't have the resources. A lot of LHJs, local health jurisdictions, don't have the resources to actually do the kinds of evaluation. Concurrently, there's also guidelines that have been put out by OSPI, the Office of Superintendent of Public Instruction, which is a little bit different. And so, long story short, rulemaking needs to be done. Rulemaking needs to be revised. We need to see better coordination between the Department of Health and OSPI to really sort of enact that type of rulemaking changes. So stay tuned for that. Today, what I want to talk a little bit about is hepatitis A. Hepatitis, hep, liver, itis, inflammation, therefore inflammation of the liver. And individuals with hepatitis, more broadly, can be either symptomatic or asymptomatic. The symptoms are listed there for you. By far and away, the symptom which is most pronounced for people to be recognized as having hepatitis is jaundice. Easy to remember, if you will, hepatitis A, B, and C. A, B, and C. We're talking about hepatitis A today. A is a vowel, and it rhymes with bowel. And so and I will give credit to Anna Halloran, who's one of our epidemiologists, for providing these slides. I would not be creative enough to think of something like this. So the transmission, demonstrated fecal oral, there is a vaccine, and there is no cure. B's, body fluids, as stated, there's a vaccine, and again, no cure. although for chronic hepatitis B, we can keep it under control with medications, which oftentimes are lifelong. Finally, for hepatitis C, it is blood-borne. There is no vaccine, but there is treatment, and very effective treatment. In contrast to a decade ago, when people were oftentimes given medications that had a lot of side effects, and the cure rate was not that great. Now, with good medications, the cure rate is approaching 95, 99%. As I said, hepatitis A, transmission fecal-oral, transmission from an infected person, contaminated food, water, or environment. And again, what I mentioned before, it's real important after somebody has been exposed to ideally get them vaccinated as soon as possible, ideally within 2 weeks. In Washington State, again, you can see the number back in '89, 2017, not many. The majority have historically in recent past been due to international travel. So endemic areas, again, third world countries, hepatitis A, very, very common. In the United States, however, we are seeing outbreaks currently, primarily commercial food establishments, but also other settings. This is from the Morbidity and Mortality Weekly Report a couple months ago. And again, almost a 300% increase from 2013 to 2015 in certain populations, again, primarily among persons reporting drug use and homelessness. This is a map going back to June 7th of 2019. Dark blue is not good. Kentucky represents a state right now with over 4,000 cases of hepatitis A. 44 deaths. It started last year. It started last year in Louisville. It moved quickly to Appalachia, where again, IV drug usage, unfortunately, has been sort of the common theme there. The state health agency has been criticized pretty heavily for not being proactive enough in vaccination, because vaccination is prevention. In this case, they were very delayed in getting vaccination efforts going for a number of reasons, and that's been sort of thought to be why they've seen it explode from 400 to 4,000. In Spokane, we have, as many know, we've had a recent cluster of hepatitis A. It began in April 12th with one individual. We now have 6 individuals who have been identified. 4 have been hospitalized. Common denominators include IV drug usage and being homeless. All have been under the age of 45. So the general guidelines, who should be vaccinated, I don't need to read these for you, but again, that's again sort of the recommendations on who should be vaccinated. Our efforts have really been outstanding, in my opinion, as well as those opinions of Department of Health. We have a concurrent hepatitis B outbreak, and as a result, we've been very proactive in outreach efforts into areas and communities where we know hepatitis B and hepatitis A can occur. The vaccine that we're using right now is called Twinrix. It is a combination vaccine for both hepatitis A and hepatitis B. Since October, when we started outreach efforts for hepatitis B, to current, we have about 950 vaccinations have occurred. Just in the month of June alone, with outreach efforts around hepatitis A, we've had 250 vaccinations provided. This graphic just sort of shows you that for Twinrix, it's a 3-series vaccine. First, then 1 month later, then 6 months later. We've been very good at getting that first dose in. Second and third doses are a little bit more challenging because, again, these populations are oftentimes very transient. What I don't have up here, unfortunately, is another slide, which I was hoping to show. It's in a different iteration of this presentation. But what it does show is that hepatitis A, Twinrix, is very effective with the first dose. It's almost a 95% effectiveness dose, efficacy after the first dose of of Twinrix for hepatitis A, much less so for hepatitis B. So by 3 doses of Twinrix for hepatitis A, I have a 99.9% effectiveness rate for preventing hepatitis A. For hepatitis B, after the first Twinrix vaccination, it's about 30%. It goes up to 70% after the second and about 90+% after the third. So it's really essential for us when we're doing these outreach efforts for hepatitis B to be having the good follow-up, but for hepatitis A, the first dose is oftentimes very effective. Any questions for me at this point? Yes, ma'am.
I had a question about, you said 6 out of 6 were in Spokane. Is that county?
County.
County,
Yes, ma'am.
okay. And I should know this, but is the regional health district larger than Spokane County? Are there outlying areas within the, it's just
We
the
are the
county?
county, yeah.
Including all the incorporated cities
Yes, ma'am.
inside? Okay,
Yeah.
perfect.
The first case, however, she did actually have time spent in Idaho before
Okay.
she was over here.
Okay. Because it seems like it'd be a region, you know, even farther than our region, our county. Yeah, okay. That we may be affected. Okay.
Okay. And I'll step down, and Mike, you'll,
No legislative report this month, right?
correct.
So, finance report.
All right, yeah, that's real quick. So last month I came and presented to you some numbers and some graphs on 2018 actuals and 2019 year-to-date dollars is what we did. And then a request came in from the Budget and Finance Committee member that was asking about, could we see the revenues by division? So that's what I sort of sent out to you this year, or this week, or this month, I guess this month. And luckily I did, it was in the packet this month, so you received it about a week ago, and should have gave you this one, that's the actual numbers that are going on. And then the other chart was, when it was in chart form, it was the various divisions in a graph to show you where the money comes from. One of the questions that always comes to me, especially when there's a federal shutdown or federal cuts or state shutdown or state cuts, is what is that doing to the agency? And what I really have noticed is where we have a very diverse group of funding that we have come into the agency. So it doesn't show quite as big a cuts when you're looking at it on the agency standpoint. However, when you look at it division by division, it really sort of does. So as you go through here, and I just sort of have a bigger version of the one that you have there now, there's the admin, but if you go down to Community Family Services, you can see that they are 79% state money. So as state money gets cut or reduced, that can really affect the programs that go on in the Community Family Service division. Moving down to the next one, you go down to Health Promotion, you'll notice they're mostly federal indirect. So it's just completely the opposite, so that's in their area. And then the other fundings that go on, as you can see, treatment services gets their money from Medicaid. 81% of it comes from Medicaid. And so even though they do have some of the other federal indirect, a little bit of state, it's the Medicaid rates that really affect the treatment service program as it moves along. And environmental public health, as you can well imagine, is they are 90% fees. So they're all based on fee-based. When we bring that fee schedule to you for passage, that fee schedule is very important to the environmental public health division on their area. And then the state money they have is some ecology grants that they have to come in to do some of the work with ecology that goes on there. And finally, as we go down to our disease prevention and response, they have sort of a mixed match of a lot of different funding coming in. So they're affected in different ways depending on the money comes in. So. What I'd like to do is each month come up here and send out, come up here and report a little something on finance. I'm going to be working with Ray and with the Budget Finance Committee on what other reports want to be seen up here. But I also welcome from any of you to send Ann or myself a request on any type of data you'd like to see from the finance world, so I'm not up here just rattling numbers for 45 minutes. And that way we can get the information you need to help us prepare for our 2020 budget that's coming up. I do know next month I will be bringing the 6-month year-to-date through June 30th year-to-date funding for both expenses and revenues. So just like I did last month on the third way through the year. So, but I can answer any questions if anybody had a chance to look through there or had any major questions or have any other suggestions now. I'm willing to take those.
No, I think the charts are very helpful for me, so I really appreciate that.
All right, thank you.
Queue up. No. So good afternoon again. Given the conversation in the past we've had about air quality and the interest in providing more information, what I thought we would do is have a number of individuals speak to you today about the issues around air quality. I will give a little bit of an introduction overview. Dr. Sam Joseph, who is a colleague in the community, a pulmonologist, will speak about the health impact and health effects. Lisa Woodard from Spokane Regional Clean Air will talk about the great work that our partner organization is doing around informing the community and making people aware of the issues. Cindy Thompson, who has been working with me on one of the subcommittees that I will talk about at the end around messaging. We'll talk about the work that she's doing, and then I'll sort of wrap it up with some more information. So this is unfortunately from the roof of Spokane Regional Health District last year. This was an AQI air quality index value of a little bit around 200. And this just is a graphic representation of what we're dealing with. Again, we're specifically talking today about wildfire smoke. There's other causes of air pollution, but specifically we're focusing on that caused by wildfire smoke. And you can see the amount of acreage that's been increasing. You can see again how it's relevant to Washington State. And the color coding is referencing the number of days with poor air quality. Dark is bad. Again, sort of a satellite photo of Washington State over back in September of 2017. Again, you can then see the number of individuals who were exposed to poor air quality by function of the number of days. The purple at the very top on the far right represents more than 15 days. I love using pointers. And this roughly corresponds to last year when we took that photograph at the top of, on the roof of Spokane Regional Health District. This is August of last year. That gray crest is the Cascades, and all the red represents the number of fires across the state at that time.
Hi, thank you. My name's Sam Joseph. I'm a recently retired pulmonary and critical care doc in Spokane, having practiced for nearly 40 years, 29 of which were here in Spokane, and now I'm fortunate enough to be associated with the Washington State Medical School. The advancement button is here. Oh, great, excellent. So thank you again, Dr. Lutz and board and guests, for allowing me to address climate change and effect on health. And you know, the image that we see, the picture of climate health, has evolved over the years. Remember the images of the polar bear floating errantly on a loose piece of ice, now evolved to a young child coughing incessantly as a result of his asthma exacerbated by weather. And now we're looking more at a global picture where man-made and environmental processes have affected all of the earth and resulted in problems with health that I want to elucidate a bit somewhat today. I think we can argue and debate for quite some time what the cause of global warming is, but I think it's undeniable and indisputable that there has been significant warming over the last several decades, and the health effects of which we're going to outline together today. These health effects are not only physical, but they're psychological effects when we deal with the psychological potential effects of nuclear and environmental changes. They are heat stresses, the stress of poor air quality, and increasingly effects of infectious diseases brought about by insects and water diseases like ticks and mosquitoes and waterborne diseases. And these affect, ironically, disproportionately those patient populations who are at the ends of the age spectrum, the young and the very old, the chronically ill, and the prematurely. And in fact, the World Health Organization points out that 88% of the current burden is borne on the shoulders of children less than 5 years of age. And Lancet, as you may know, is a British medical journal, well respected, and they noted just within the last less than 2 decades, the people who've experienced heat waves has increased by more than 150 million vulnerable people. And in fact, they point out that when the exposure to smoke and vehicle exhaust has resulted in almost 3 million premature deaths in 1 year alone in 2015. In addition, we have these vector-borne diseases, food shortages as a result of climate change, mental health impacts. All of these are becoming more prevalent and will continue to mount up. And again, ironically, these findings confirm that the problem affects people who did the least to create the problems, yet they're being disproportionately affected by the consequences of those actions. The World Health Organization, without getting political on this, I just want to point out what their report said, is that if we were to abide by the 2015 Paris Climate Agreement, we could save millions of lives and, in fact, hundreds of billions of dollars by the middle of this century. And in fact, they showed quite convincingly that we could save 1 million lives a year from pollution alone by 2050. So what is driving this problem? Well, clearly the bridge between climate change and bad health is air quality. And what drives bad air quality is burning fossil fuels for any number of reasons, some of which are avoidable and some unavoidable. But what are the results? Human effects of this are an increase in child mortality, increase in adult heart and lung disease. We talked about the 7 million deaths. Ironically, there's no safe amount of particulate matter, unlike the parts per million that may contaminate our food or water sources. And what we can do is very simply reduce fossil fuel use. But the caveat being, the longer we wait, the more this problem potentiates, and the effects are more dire and more difficult to remediate. So the economic and health effects are certainly global, but they're also local. And I'm often asked, well, as a physician, how is it during bad air quality? And it's very difficult from an individual perspective to say, oh yeah, we've got a lot more respiratory diseases during bad air quality, as Dr. Lutz pointed out. In point of fact, we're always busy, and I really can't say from an individual point of view, but from a public health officer and group perspective, it's easy to see that it is both a global and a local issue. And these are data from the U.S. climate assessment in 2 decades just ending, that King County, during a heat-related process, extreme heat days, saw a 2% increase in heat-related hospitalizations and a 10% increase of deaths during those events. And during smoke events, in just a 5-year period, there was a 7.2% increase in respiratory hospitalizations for adults, particularly over 65 in eastern Northwest. That's us. So it is, in fact, a global process, but indeed a local one as well. So what is the driver of this particulate pollution? It's particulate matter. We all have heard that. And these come in many shapes and sizes. And just very briefly, they include organic and inorganic acids, smoke, compounds, dust, chemicals, and increasingly biologic compounds such as molds and pollens. These particles that typically affect us, as you probably know, are particulate matter, PM10s, and these reflect not only particles of 10 microns or smaller, but all of those micron particles. And the thing to understand is the smaller the particle, the more deeply they migrate into the depths of our lungs and cause further damage. And again, to point out that the people who are at greatest risk are those with heart and lung diseases, people with underlying illnesses such as diabetes, and the extremes of ages. Those particles larger than 10 micrometers are not harmless, however, and they affect eyes, nose, and throat, even though they don't reach the depths of our lungs. And these PMs are divided into coarse, fine, and ultrafine, and even nanoparticles down to even the 0.1 micron. And note that, again, the smaller they are, the more deeply they migrate into the depths of our lungs. And when we see the term PM10, it refers to all of those particles, not just the ones that are 10 microns. So all of them, 2.5, 1, and below, are all encompassed in that term of PM10. So to further break that down, there are primary particles, those which are produced from a direct source like fire, road, or smokestacks, and then there are secondary PMs that occur as a result of complex atmospheric reactions. And I point this out only to say that there are a variety of sources of particulate matter, not only exterior, but also interior, like cooking and vacuuming, dusting. So this is what happens in an inversion. You're probably well aware that when cool air falls, it traps warm air in the midst, and that the warm air containing particulate matter is not able to rise in the upper atmosphere. And this then exposes us to the effects of particulate matter on the ground. And I'll tell you about one instance in a moment. But that results in a variety of respiratory problems: cough, phlegm, wheezing, and it creates a decline in measurable lung function that we do in a lab with a pulmonary function test. It results in inflammation of the airways. That inflammation causes what we call bronchial hyperreactivity, whereas inhaled irritants can cause vaso and bronchial constriction in the lungs. And this causes a whole host of immune responses that we call the acute phase response, and resulting in infections and further inflammation in the airways. And as a result of all this, we get increased emergency department visits and hospitalizations. There's decreased lung growth in children and a decline in lung function in adults, and indeed premature mortality in people with chronic lung disease. And this is just to reiterate that those in a lower socioeconomic status and these with pre-existing diseases are at greatest risk of pollution-related health effects. And very briefly, again, to reiterate, is that inflammation is a result of this inhalation, and that results in hyper-responsiveness and bronchial and vasoconstriction. But in addition, that inflammation can kill or damage cells, which degrades the barrier between air cells and blood vessels, and that allows particulates and toxins and bacteria to migrate into the bloodstream and be dispersed throughout the body. I grew up in southwestern Pennsylvania, and when I was in college, I found out about an episode that occurred a couple years before I was born on the Monongahela River, on which I lived, just a few miles away in Denora, Pennsylvania, and I had family that lived there at the time. This was in an era where there was an incredible amount of soot, as we knew it then, and smog in the air. Post-World War I, U.S. Steel and U.S. Iron wire works were very active in the Monongahela Valley. And in June of 1948, there occurred an inversion, which was showed in the cartoon a moment ago, and that inversion resulted in nearly half of the population of this town becoming ill. And within 4 days, 20 people died. And within the next month, another 50 died. So it was an incredible wake-up call to recognize that what we are doing in our environment is, in fact, of great consequence. In contrast to that, in Southern California, over the last 2 decades, and in 2012, it was found that as we improved the ambient air quality, the levels statistically showed there was a decrease in bronchial symptoms in children, particularly those children with asthma. So we don't talk a lot about or hear much about carcinogenesis, development of cancer as a result of air pollution. But in fact, there are these 2 studies that I wanted to share with you. One by the International Agency for Research on Cancer, and then a meta-analysis, which is a compilation of many studies put together. In fact, both of these showed that there is, in fact, a significant correlation between air quality, inhalation of particles, and the development of cancer in humans. So what can we do collectively and as individuals? As a healthcare worker, I was limited to dealing really with the patient in front of me, and I could certainly tell them avoidance techniques, things to do to improve lung function, improve the air quality in their home, stay away from activities outdoors during bad quality, use filtration devices and whatnot. But on a more global basis, what we really need are things that we can do as health organizations. One, we can resist the new fossil fuel projects, which are being offered increasingly more often. We can encourage our legislators to act in a manner that is in consideration of climate control and knowledgeable of their consequences. We can promote actions to reduce carbon emissions by promoting individual and group use of alternative transportation, for instance, walking, biking, using scooters, electric vehicles, for instance. And we can encourage our elected officials to be aware of and promote climate goals. So these can be as broad-ranging as the GMA, the Growth Management Act. I read an article this morning where language is going to be included in the GMA in the state to include a language revolving around climate change. And then as an organizational matter, I think we as public health officers, or you, can and should track the progress that we make in our healthcare as a result of these remediation efforts. So organizationally, again, what we can do is join organizations. I'm a member of Physicians for Social Responsibility, which was very active here in Eastern Washington, started by several of my colleagues years ago, but has become less so recently, but still active on the west side of the state. There are legislative fora and environmental activist groups, one of which is 350 Spokane, a branch of 350 nationally, started by Bill McKibben in an effort to decrease pollution and particulate matter. And to quote the World Health Organization, this is an area of opportunity for all of us. If we can improve our health, it'll save lives, it'll save money, and it'll stimulate economic development because people who are healthier tend to be more productive. So I see this not as just a health-related issue, not only as an economic issue or political issue or environmental issue, but one that involves all of those aspects, and one in which I think all the stakeholders in each of those areas need to work collaboratively with one another, so that is, as Congressman Wellstone said, we all do better when we all do better. I love that quote. Thank you, Bob. And so we save lives, we can improve health, and we can save money. So it's a win-win-win if we all work together on this. So I want to thank you for the opportunity for that brief overview, and happy to answer any questions. Thanks, folks. Yes, Brian. Breathe.
So I have been obsessing on the issue of the soccer coach who has to decide whether to cancel practice right before the big tournament, or just the person that's going to go, who's training for a marathon, whether they go running that day or not running that day. And it seems like with wildfire smoke, depends on the wind, it can change quickly. And a lot of the monitoring, I'm understanding, we're getting 24-hour reports or 12-hour reports. And I'm just wondering, from a health standpoint, is what it is for the next hour, does that make a difference in the health, or is it really the cumulative over 12 hours or 24 that's the significant?
Yes, there's definite cumulative exposure that has a grave effect. But as you noted, the data that we see is based on a time-weighted average. So that really isn't helpful for day or point zero at the time that we want to go bicycle or practice soccer or go for a run. So we have to use our best judgment, and we can issue guidelines, but there really isn't any hard and fast things that we can say, the last 24 hours have been 150, you shouldn't go out and exercise because the wind may shift and may clear up. So I just urge my colleagues and my exercise buddies to use our best judgment. If it feels bad, it is bad, don't do it. And as far from a public health perspective, it's a very tough call because obviously people, money, resources go into planning for these things, and it's difficult to call off an event, for instance. But again, I think we have to keep the public health in mind and use our best judgment in order to facilitate the best response.
All right, thanks.
Thank you.
It's really just for the board members right now, but he might be able to chat with you afterwards.
Happy to chat with you later.
Yeah.
Thank you.
Thank you.
Thank you. That was really interesting, Dr. Joseph. I'm Lisa Woodard, and I'm with the Spokane Regional Clean Air Agency. It's a pleasure to be here today. We've enjoyed a long-term relationship working with the health district, and we appreciate those opportunities. I'm here today to share with you information about air monitoring, how we do that in Spokane, and then some of the collaborations we've done with Spokane Health District in terms of wildfire smoke. So let me get familiar with my little arrows and everything here. So I know there's an easier way to forward. Oh, the center button. Thank you. Thank you. Here we go. Okay, so I guess the good news is most of our air quality days are in the good range. I think we should be very fortunate living in Spokane that we can't lose sight of. We have good air quality here on most days. We consider good air quality that falls in that green category. Last year we had 263 days and we had 88 moderate days. So we're actually having fewer moderate and a few more good. It kind of varies year to year. And then you'll see, sadly, that in 2018, actually starting in 2015, that was our first significant year of wildfire smoke impact. We had 5 unhealthy days. And then we skirted by in 2016 with no days over the health standard. And then 17 and 18 were pretty bad years. I don't have to tell any of you here that were living here at the time or in Spokane. So here you go. Here's a picture. We saw an earlier picture on August 19th. I'm not sure which date this was taken. But we have had 42 days over the last 3 of the last 4 years where we've had unhealthy air quality. Real quick slide. I know Dr. Lutz had a slide about acreage in Washington. We had over 1,700 fires in the state of Washington, and 84% sadly were human caused. These are avoidable fires, which means the smoke could be significantly reduced if we can tackle that. A lot of them are contained initially, and about 3.5% became very, very large fires, which obviously would impact the state. We did have a lot of fire from Canada as well. In terms of acres burned with air quality, though, it doesn't always go hand in hand. This slide shows that our most significant year with acreage was in 2015, and that resulted in 13 days of bad air in Spokane. And then last year, we had about half that, and we had 13 days as well. So it really depends on where the fires are happening and the wind directions as well, where that smoke is being carried to. So our main role at Spokane Clean Air in terms of wildfire is monitoring. We operate an air quality monitoring network. We have 5 sites for fine particle, and this is the PM 2.5 that Dr. Joseph mentioned. These are the combustion-related particles that lodge deep in our lungs and can scar and damage lung tissue. We have 5 sites typically up and running. We have had a site down in Airway Heights for over a year. We lost that site. And any day now, we should have our site in Airway Heights restored. So we will be back up to full force with 5 PM 2.5 monitoring sites. Our monitoring sites are set with very, very strict EPA guidance. It's in regulations in terms of how these monitors are sited, what criteria is used, and they're Q&A'd and they're audited, and we have data validations. I mean, an awful lot goes into our monitoring sites and how this data is collected and how it's validated. And basically, our air monitoring network is set up for one key purpose, and that is to ensure that our air quality meets national ambient air quality standards. There are national ambient air quality standards for 6 pollutants. In Spokane, we have issues with 2 of those 6, fine particles, PM 2.5, and ground level ozone, which is commonly referred to as smog. So our monitoring is set up to ensure that we are in compliance with Spokane and with the national standards, and we haven't always been in compliance. We are currently in a maintenance area for PM10 and for carbon monoxide. Once we reach attainment in early 2000, we have 2 10-year maintenance plans. And so we're in our second 10-year maintenance plan for PM10 and carbon monoxide. So anyway, we maintain and operate a network of monitors. We use this data for many things, reporting to the community what the current air quality is, and providing a 2-day air quality forecast. Forecasting during wildfire season is very challenging. There are a lot of models that are looked at. There's smoke dispersion models and fire models, and there's phone calls with weather service. A lot goes into forecasting. And then the data is reported onto our website for the public to take action, so that you don't always have to just look out and make a judgment call, that you can actually go to a website and get current air quality, and it's updated every hour. This is a slide of August last year, a month that we're trying to forget, and this shows how closely our different monitoring sites track across the county. And so here we've got the 4 sites that were online in August. And so we measure the micrograms, and the micrograms are then converted to an AQI scale that most of you are most familiar with. And so this is showing that tracking. And it's showing that we not only had high levels of PM 2.5, but we had so much PM 2.5 in the air that we actually violated the PM 10 standard, because that's 150 micrograms for 24 hour, and the PM 2.5 is 35 micrograms. So we had some serious issues that August day, or a couple days that August as well. And I just want to point out that since I'm talking about air quality monitoring sites, is that and I know some folks here are a little bit familiar with the personal sensors that are gaining a lot of popularity. And I think these personal monitoring devices do have a lot of benefit. I think that they are used, can be used, and are being used by schools for educational purposes. And I think that as the technology becomes more and more sound, I think that we'll be seeing more of these. In fact, EPA is, their Office of Research and Development has been looking at personal monitoring for quite some time, and they host webinars and trainings. They're looking to get more solid guidance on the calibration and how these are used, because they're completely different than what a stationary monitoring site would provide. Completely different technologies, and it's a totally different ballgame in terms of personal sensors and stationary monitoring sites. So again, I think that they can estimate pollutants. They're not correlated, they're not calibrated when they're delivered, and they're just, I can't emphasize enough that they're not to be confused with stationary monitoring sites that must meet rigorous monitoring regulations that are established by EPA and provide high quality data. So sensors, I mentioned, can be useful for things. How's my air quality indoors compared to outdoors? How's my air quality compared like at home versus work? So I think you can use those for some comparison purposes. But in terms of making daily decisions on your activity, I would send people to our website. Here's another quick snapshot of August, and I'm showing this because during that poor air quality period, not only did we violate the PM 2.5, but we also, the PM 10 is this black chart here, this black graph bar. And so we, anytime we go over 100 on the AQI for any pollutant, anytime we go over 100, that means we were over that health-based standard. So that shows we had an issue with ozone as well on those days. So I'm just going to show you briefly our website for those of you that haven't visited it. When you go to, let me just go to it right here, because I want to show you when you log on to our website. Whoops, you guys are just a little slower. So, whoa, that's big. That's zoomed out. How do I zoom in? Or zoom out? Oh, I'm opening all kinds of things. Zoom out.
Yeah, let's see, you're asking somebody who's not very technically savvy too, so. Hey?
Control minus.
Thank you.
Do I even see a minus?
No, where are our tech team when we're not?
Thank you. Awesome. Thank you for, I guess I haven't had to do that before. Hopefully I'll remember that. So when you log on to our homepage, this is what you see. And over here is just a quick link. A lot of people have this bookmarked. So here's a quick link to our air quality page. So this is where you have our current air quality. And I'm going to explain what current means, because I think there's some confusion with that as well. And so we also provide the forecast here, so you can click on the forecast discussion and you can see what we're saying in terms of the forecast, which is helpful especially with wildfire season. And if you scroll down, you'll see our monitoring locations. The AQI is driven by the predominant pollutant. That's what drives the air quality index. So right now, ozone is the predominant pollutant. The levels of ozone are higher right now than particulate matter. And that's why ozone is being reported as our AQI. We have one AQI for the entire county. And we are required to report that for a community of our population. We are required to provide a daily AQI. So right now we're sitting at 31 with ozone, which is good. We're in the good category, yay. And so here's our monitoring. Now, if you wanted to say, wow, that's great about ozone, but I want to see what PM's doing, you can click onto a PM monitoring site, and you can get hourly concentrations, which have no health recommendations for hours, because there isn't a health-based standard for an hour. And then if you get, this is where we go a lot. People want to know what the trend was. Well, how bad did it get yesterday? And so this is a trend chart for 5 days. You can click on 2.5 and see what's happened for the last 5 days. A lot of up and down variability. So I just want to point that out. I also want to point out when you click on current air quality, it describes what the air quality index is, and then you go down and it says we provide two, this is really the important part of what I want to share today, is that we provide 2 air quality indexes. We provide a daily, and that is what was reported to EPA. Are we in compliance with the health-based standards? The health-based standard for fine particle is a 24-hour exposure. That is what the health-based standard is for national ambient air quality. It's a 24-hour exposure. So we provide a daily and we provide a current. And about 10 years ago, our current air quality report wasn't being responsive to rapidly changing conditions. It was every hour it was giving an update to that 24-hour picture. So you'd have an hour of bad air quality when we had a dust storm, and you'd have 23 good hours. So people would call us and they'd say, I'm looking out my window and I can't see across the street, but your website is saying good air quality. And we would have to explain the standard is 24-hour exposure, and we've had 1 bad hour, but we've had 23 really good hours. So it's going to take 4 or 5 hours for this to respond. That's when EPA said we need to come up with a nowcast. We need to come up with a calculation that's going to be reflective of current conditions so that people can make health-based decisions on what they're going to do. Because the health standard is 24 hours, we wouldn't be able to tell people till the next day just how bad yesterday was. So that doesn't do people any good. So this nowcast is a way to report current conditions versus daily averages. And it's a way that people can take timely action to reduce their exposure. EPA scientists looked at thousands of data points when they came up with the nowcast calculation. And I think what throws people off too at times is that they use the word weighted. And I think perception-wise, people may think that weighted means slanted, but what it's doing is it's taking the air quality that is most recent and it's giving more weight when conditions are rapidly changing. So if we have a wildfire smoke move into the area or a dust storm move into the area, the current air quality is going to reflect those most recent hours that are happening. We don't provide a 1 hour, just a standalone 1 hour. We have nothing to base that on. There isn't an air quality standard for 1 hour. So if we told someone your 1 hour standalone was 15 micrograms, which equates to whatever on the AQI, we wouldn't be able to say what you should do because there's no health-based advisories on a 1 hour. And so that's been really challenging for our agency. We get calls from coaches and people during wildfire season, and they want to, kind of split hairs when it comes to can we hold practice in this part of town or that part of town? And it's like, well, this part of town, this monitor is reporting this, but by the time you drive out there, that monitor might be reporting what this monitor is reporting. So we encourage people to go by this AQI right here. This is the AQI that represents our county, our airshed, our ambient airshed. So I want to make sure if there was anything else I wanted to point out before I have a couple other things that I want to talk about, and I'll probably leave our website. One thing we get asked a lot about, just really quick, am I okay on time? One thing we get asked a lot about is, I'll go home. I'll go to home, and right now we have wildfire smoke feature article up right now because we've been working with this topic. But a lot of people want to know how bad is this? How bad, especially the media, is this the worst it's ever been? So we have various materials on this site. We have links to pages on the health district site. But we have a table of, and we don't put yellow on our tables because yellow is still considered within the health-based standards. So we just focus on the orange, red, and purple and above. So these are the number of days. Obviously, this is a small chart. But we keep a running, if we have another orange or red or purple day, we'll add it to this chart. Our last day was in August of last year. So we haven't had to update it. And wouldn't it be nice if we don't have to update it this wildfire season? But I have a feeling, based on past years, we will have to do that. So I'm going to get away from my website and see if my PowerPoint's still up. And just to point out a couple other things before I move on. And I'm open to questions regarding how our AQI works. So Health District, in 2015, when we had that severe episode, our first real wake-up call that wildfire smoke is going to be an issue in our community, we reached out to the Health District, and we have been working together to get materials and information out to folks. We both have websites where we have smoke information. EPA is a great resource. The Washington State Department of Ecology and the Forest Service came up with a great blog, the Washington Smoke Blog, and that's available. If you're traveling to other parts of Washington, that's a great place to go. We respond to media inquiries. We try to coordinate those. We use social media. We do news media interviews. We recently presented in early May. Our agency in the Health District was asked to present to a group of providers of programs that serve babies to age 5. They were talking about summer air quality, and so we presented at that. And then yesterday we hosted our first ever Smoke Ready Communities Day, and that's something we hope to grow each year. That mainly consisted of a social media campaign and some media. So we're working together to provide information about air quality, sound, technical, scientifically based information about air quality, so people can make the health decisions, and then so that public health can then make those kinds of recommendations as well to folks. So I'll end it at that. I've probably gone way over my time. But if there's questions about our monitoring, and then also just, I would like to say that we would host folks to come out to our agency and meet with our monitoring staff if they want to really get into nitty-gritty monitoring and how it all works and how the equipment works and is calibrated. We go up on the rooftop and look at a monitor. It's pretty interesting, actually. Or we can come to you and present as well. So I want to thank you for this opportunity.
Thank you.
You're welcome.
Any questions from other board members?
And if we can just have 5 more minutes, is that okay? 5 minutes?
I'm going to do a speed session.
Yeah,
Thanks. All right, well, thanks. I hate to be the very end of the show here, but thanks for staying, people. Oh, you are, that's right. Okay. All right, I'm Cindy Thompson. I work in the Public Health Emergency Preparedness and Response division upstairs, actually team, and my division that I work in is the Disease Prevention and Response. So that's a huge mouthful. So what I want to just share with you a little bit today is sort of what the public health, what our role is in wildfire smoke, because oftentimes we get asked to do a lot of different things, but our primary role is to be informing the public and working with the media on information that helps them make good decisions about their health. What's my trick here? Just that button there?
Yeah, just roll it.
Okay, all right. Before I do that, though, Linda, you asked a great question earlier if we were just Spokane County, and we are just Spokane County and have jurisdiction here. However, the program I work in is the lead for what's called Region 9, so all of Eastern Washington small health jurisdictions, and that consists of 10 of us and 3 tribes. And they are very small health jurisdictions, so oftentimes we are providing a lot of support and technical assistance to them because they have very small staff and very limited capacity. All right. Dr. Lutz is going to talk in a minute about some of the committees we've been working on, but after the last couple of seasons of a significant wildfire, our Department of Health and LHJs across the state have said we have got to do something. We have got to collaborate and get on top of this incident, this wildfire incident, because the smoke is impacting our entire state. So the work group that I've been on is the communications work group, and we have created a lot of templates and materials that are available and can be used across the state. The goal is to have consistent messaging. Oftentimes we're saying something different than our partners on the west side, and it's very confusing for people. To do that, we have a tool we're using called Basecamp, and it is already something that the State Department of Health communications team uses, and they've invited a lot of us to participate in that tool. It's where all of our materials are stored,
And so the templates are there. So a great example of that is the small health jurisdiction who has maybe 3 staff, and the WIC coordinator is the person in charge of the media or the messaging or the information for her area, and doesn't really have the capacity, but this allows her or him to get into that base camp and have some tools available. I'm going backwards. I want to just emphasize some of the key partnerships, as Lisa mentioned, that we are participating not only at a statewide level, but in Spokane, we have collaborated with a lot of partners. Spokane Regional Clean Air Agency, the Department of Ecology, the Eastern Regional Office, our Greater Spokane Emergency Management, Labor and Industries, and our State Department of Health as well, to come up with what is it we're going to share with our communities and how are we going to share that in a consistent way. Of most importance for us at the Health District is to be ready to prepare our staff for the season, because we have a lot of folks that work out in the field, out doing home visits, and we get asked a lot of questions. Is it safe to go out? So one of the things that we do internally is get our group together and start preparing messages for our staff. And also the point of our meetings internally is that we are looking at and listening to what our community is asking us. So through phone calls or social media, we take that information and then prepare our responses. Did it again. All right. And lastly, I just want to provide you with this slide, because while we heard some great information from our previous presenters about what's happening in the Pacific Northwest and climate change in general, wildfire smoke is a reality. And while the firefighters are on the front lines doing their job, a lot of us are behind the scenes doing our job, preparing the information, preparing the materials. And so that's just really key as well. We all have to be working together to protect our communities. All right, Dr. Lutz, that was swift.
So I'm just going
Is that
to,
you?
since we've gone over, and again, I appreciate everybody's willingness to stick around, but I also am sensitive to everybody's times. What I'll do is next month, I will sort of come back and discuss more specifics around some of the recommendations that will be coming out of the Department of Health and the working group that Cindy alluded to. Essentially, there have been 3 working groups. I've been involved with a working group around closures of outdoor events such as county fairs, sporting events, and then also what we would be recommending to schools with respect to closing schools with respect to indoor air quality. So I really want to have time for questions. And again, the documents that we will be using have not been finalized. They're still draft, and so I think I would prefer to come back in July to discuss those recommendations. So I'll just leave it with that.
Sounds good, thank you. Any further questions? No, we seem to be dropping like flies. Board member check-in. Chuck, do you have anything for us today? No? Mary? Linda?
I was just going to say, we're at the Association of Washington Cities this week. We left the conference to come to the meeting, and health issues are something we're discussing among city leaders across the state. And one of the things I'd like to look at is what resources each city, town, county has for health. Like, do we have a Neighborhoods Matter in this community? Do we have a Drug-Free Communities grant in this? Do we have a health clinic? You know, I just think that our legislators need to see the importance of health and addressing things like climate change, wildfires, that kind of things. And so that's something I'm talking about with our constituents over at the Association of Washington Cities.
All right, thank you. So just as a reminder, our next regular board meeting is July 25th. And so do I have a motion for adjournment?
I move to adjourn.
Is there a second? All right, all those in favor, please signify by saying aye.
Aye.
All those opposed, we are adjourned.